Week 8, Molecular and Genome-Based Diagnostic Test, Ethical Counseling and Reporting Issues in Genetic Testing. The learning objectives for this week are to give examples of tests currently available on chips and multi-gene panels, use resources available to explore the potential clinical significance of variants, give examples of predictive tests and predisposition tests, perform risk assessment of data from SNP genome association studies, to discuss genetic testing for diagnostic and screening purposes in various groups, and to discuss counseling reporting issues related to genetic tests, including informed consent, privacy issues, and challenges and responsibilities in sharing genetic test results with family members. A genome-wide association study, a GWAS, is a way to identify genes involved in human disease. What it does is it searches the genome for small variations called single nucleotide polymorphism, or SNPs, that occur more frequently in people with a particular disease than in people without the disease. Each study can look at hundreds or thousands of SNPs at the same time. Researchers use the data to pinpoint genes that may contribute to a person's risk of developing a specific disease. These studies are very promising because it will help us to study complex common diseases in which we have many genetic variations which contribute to an individual's risk. Direct-to-consumer testing actually many of them utilize SNPs. We can look at such diseases as diabetes and Parkinson's and heart abnormalities, and the future hope is to identify more SNPs associated with these diseases and SNPs associated with responses to drugs and interactions between genes and the environment. Please go to this YouTube video, which is on GWAS studies. Let's talk about gene panels. For many hereditary disorders, there is substantial locus heterogeneity. Recent advances in DNA sequencing have made it possible to analyze large panels of dozens to over 100 genes simultaneously, and it's cost-effective for mutations in every gene in which mutations have been seen previously to cause the disorder. For example, here are some of the gene panels that exist. Congenital myopathy sequencing panel. You can go to invitae.com to look at some of the panels that they have at this site. Some other examples of panel tests are Colonex from Ambry, colorectal cancer panel, GeneDx, Lynch syndrome panel at Invitae, and Myriad MyRisk hereditary cancer. And I know that in your cancer course you were discussing many of these panel tests, and we will be looking at some of these tests as we go through your other coursework here in this program. This slide is just showing you how many genes can contribute to hereditary cancer. You've seen this before, but just to emphasize the fact that multiple genes can increase the risk of a single cancer, and you can see these various genes that are found in the Myriad panel that was just mentioned, the MyRisk panel. And then you can see that multiple cancers can be associated with a single gene. In looking at panel testing and variant interpretation, we see that the use of large gene panels and whole exome or whole genome sequencing has raised special issues for sequence interpretation and risk assessment. The more genes that are studied, the more variation arises. Many previously undescribed variants have been found whose pathogenic significance is not known at this time. Particularly is the case for missense mutations, which result in the substitution of one amino acid for another in a protein. The American College of Medical Genetics and Genomics has recommended that variants be assigned into one of 5 categories, ranging from definitely pathogenic to definitely benign. Risk assessment and genetic counseling can change depending upon the reclassification. And as the new information is found, it is communicated to the healthcare providers and then on to the patients. If we look at Ambry Genetics and how they classify the variants, they classify them as a pathogenic mutation, a variant likely pathogenic, a VLP, a variant of unknown significance, a VUS, a variant likely benign, VLB, and benign. Ambry Genetics, just like Myriad, has family studies, which is in a follow-up testing of appropriate family members that can provide additional information to aid in the VUS classification. The value in this is to assess if a variation is inherited or it is a de novo mutation, and to determine segregation with disease. A VUS can be challenging to physicians and to genetic counselors because there's no verification that you have, and patients ask a lot of questions about this. So you have to be very clear when you're telling them that at this point in time, this is all the information that we do have. Myriad classifies the variants as deleterious, pathogenic, suspected deleterious, likely pathogenic, a variant of uncertain significance, favor polymorphism, which means you favor normal human variation, likely not pathogenic, and polymorphism, normal human variation, only not pathogenic. The classification in the report is sent along with recommendations for managing patients based on genetic and familial risk. If a VUS is reclassified, healthcare providers are notified. Let's look at informed consent. All of us have the expectation that our personal health information will remain private and confidential. And in actuality, this is the expectation that's codified in the HIPAA regulations. And every healthcare employee is expected to abide by these regulations. When an individual first seeks care from a provider or healthcare institution, they're required to acknowledge that the organization has shared its privacy policies with them, and they are aware of any situations that might require the sharing of such personal information, such as when insurance claims are filed or referrals are made. Patients have the right to refuse to have specific information shared. Also, we all have the right to determine whether to share our personal information with others, including family members. The process of informed consent is an important concept. It is more than signing a document authorizing the conduct of a test or procedure. Informed consent should always be made at the end point of informed decision making. Healthcare providers are obligated to provide consumers with information that includes the type of test or procedure to be performed, the risks associated with the procedure, and the risks associated with not having the procedure performed. The information needs to be presented at an appropriate level to ensure comprehension. This is not always easy. The person actually performing the procedure needs to be assured that the patient knows the risks and benefits of the procedure, including any adverse consequences. Only after the procedure has been fully explained should a signature be obtained. Some issues that can come up when you're doing genetic testing are some family members may wish to not share their information with other family members. They may find out that they have Lynch syndrome, but they don't want to tell their brother or sister, or they may be estranged from various family members. Some family members may refuse testing, and therefore other family members may choose to be tested, but then you might run into problems with insurance. And does the person who wants to be tested have insurance? There are situations at some medical centers, and the medical center actually that I'm at, where we do have charity cases. We do help the patients, and also if you work with some of the companies like Myriad and Ambry, you can get some assistance with them. Insurance companies may not want to test someone. They may not want to pay for it. And let's look at Medicare. If you have a patient who has a lot of cancer in her family, but she herself does not have cancer and she is on Medicare, then they will not pay for it. And you can run into other problems with this. Newborn screening is a public health initiative. And these state newborn screening programs test nearly all infants born in the United States for selected inherited and congenital conditions that may cause disability or death. The screening is mandatory in all but a few states. In addition to screening, the programs provide education, follow-up to definitive diagnosis,
and long-term treatment and management. And they can also link affected infants and parents to resources. Now, the ACMG report had 29 core cases, and they argued that it was appropriate to depart from the criteria of having a informed consent because you needed to consider the benefits to the family or society rather than those of the infant. For example, early diagnosis of an untreatable genetic condition may allow parents to plan ahead for a time when the child's symptoms appear and perhaps to alter their reproductive decisions to avoid the birth of another affected child. Early identification of affected children can also benefit research on the condition by providing potential human research subjects and residual blood samples. However, this has been a problem in many states where they were not storing their test samples. They were just giving them out to researchers. But this is now being addressed. Let's look at this case study. Some of the things that a genetic counselor may come about with genetic testing. After appropriate informed consent, Mary is screened for cystic fibrosis early in her pregnancy, and the test results indicate that she's a carrier for a common cystic fibrosis mutation. You share the results with her and suggest that the next step would be to have her husband tested. She tells you that this pregnancy is a result of an extramarital affair. Her husband believes that he's the father, and the man with whom the affair occurred is not aware that he fathered Mary's baby. So, what are your responsibilities to Mary? Should you inform her husband that he is not the baby's father? And do you have a responsibility to tell the baby's father of the situation so that he can be tested? If he agrees to be tested, whose insurance is responsible for paying for the test? And do you have any obligations to the fetus? So let's look at what are the answers to this case study. Mary's your patient, so your responsibilities are to her. It's up to Mary to share the information about the paternity with her husband. The question of the insurance coverage for the genetic testing of the non-marital partner is dependent on the particular coverage that this individual has and is not easily determined. The question of legal obligation to the fetus may depend upon state law determining personhood. Let's look at the genetic testing of children. Well, the issue of genetic testing of children is complicated, and it's complicated because children cannot provide informed consent. Children are not aware of the complexities of genetic testing or of the potential life-altering consequences of the test results. Parents may wish to know whether their children are at risk for conditions that run in families, but do they have the right to know? Will this knowledge alter the parent-child relationship? This is especially true of conditions for which there are no known preventions or treatments. It has been suggested that testing be deferred until a child is sufficiently mature to provide informed consent. This may be a problem if the child becomes sexually active and runs the risk of transmitting the condition of concern to offspring before they are sufficiently mature to determine when or whether they will be tested themselves. In some cases, testing of children may be justified. For example, if a child is at risk for congenital colon cancer, the standard screening for early detection is an annual colonoscopy, perhaps beginning as young as the age of 10. If a child undergoes genetic testing and is found not to carry the gene, then the child is spared this annual invasive procedure.
In looking at those individuals who have a predisposition to a disease, testing asymptomatic individuals for diseases that may have an onset later on in life, such as Huntington's disease, no cure, and has a devastating disease as we've discussed before. It's a highly personal decision to do these tests, and it requires a lot of support. Another example of a test such as this would be the BRCA1 or BRCA2, But the BRCA1 and the BRCA2, unlike the Huntington's disease, allows for early intervention and early treatment. And individuals who have these genes have a 50 to 90% chance of developing breast or ovarian cancer. They'll need increased surveillance and perhaps they will have prophylactic surgery. In the case of those diseases where you have a predisposition to a disease, the decision to be tested or not requires informed consent.
So, beginning in the fall, when you become a second-year student, you will be getting a Gene DX experience where we have a course that will be embedded in your coursework. And this course aims to teach concepts related to laboratory genetic counseling and to provide the skills most needed to work in a lab and to order the genetic testing appropriately. So you're going to learn how to do the flow of the sample through the lab. You'll learn the different roles of a genetic counselor in the lab and the benefits, limitations of working remotely. And you'll learn how to order the various tests, the panels versus the targeted versus the exome sequencing, how to order the various studies, when to send a positive control, etc. You will also learn how the laboratory genetic counselor uses very important psychosocial skills that you're going to learn here in graduate school, and how the genetic counselors at Gene DX have moved into management roles and talk about genetic counselors supervising other genetic counselors. And you will be going through the ACMG guidelines for variant interpretation and how to incorporate into your reports that you will be writing. And then you'll learn the unique and incidental findings both within and outside the exome sequencing. So we are finding that this is an exciting course, small course to include in your coursework here. The University of Pittsburgh program uses this, and some of the other programs are looking to include it into their curriculum too. In October, the New York Newborn Screening Program is going to be coming here to speak to you about their whole process, and you'll be doing some workshops on newborn screening. Quest Labs, we're looking to come and visit here, and you can also go to Marlborough, Massachusetts to visit them. And in closing for week 8, you have a case study to complete, and your test is also, or quiz is also up. And what I wanted also to tell you is the test is essay questions. These are not short answer. I mean, the short answer, they're not that long, but they are not multiple choice. So I wanted to prepare you for that. So when you're going through it and you're looking and getting your notes out from this course before you take this test. Okay.